Good evening, everybody, once more for our fourth week of IT and Health Informatics. As always, we will leave it just literally a minute or two while everybody comes into the webinar room, as it is. Again, as always, we would encourage you to say good day on the chat. Chat, say hello PS. And also remember, questions. If you've got good questions, in fact, if you've got any questions, because all questions are good, please put them in the Q&A and Dr. Mohammed or Dr. Basu will answer them. Today, at the end, we'll be answering most of the questions in one big chunk at the end of the session. We won't split it up too much. While we are waiting for everybody to come in and get started, I will go through a few reminders and a bit of housekeeping first. So first thing is, welcome again. I hope you're all feeling good today and ready for module 4 of our course. Apparently my audio is a bit dud today, so I will do the best I can to work through that. But I will give you some reminders. Remember to lodge your webinar chat to everyone, not just the hosts and panelists, which often is the default, and have fun chatting to each other in the chat. We will have the exam will be available after this session sometime. In order to be able to sit the final exam, you have to have passed the 4 quizzes from each of the weeks. So remember to sit the 4 quizzes and then the exam will magically appear in your learn.itmasters.edu.au portal and you'll be able to do that. And then of course, when you do sit the exam, we will be issuing certificates as well as part of that process. I would also please ask everybody, if you get a chance, to fill in the survey that is sitting there as well. I think it's sitting on the learn.itmasters portal. If you've got 3 minutes, there's only 3 or 4 questions, please just phone some answers in. We always like to hear back from you about the content. So, and finally, the other thing to remind everybody about, for those that you haven't heard already or had a note about it, I'll stick a link in the chat in a few minutes. But the webinar that we are running next week for the CHS College of Health Sciences is again given by Dr. Mohammed Khalifa, and it is about AI. And actually, there we go. We've got it all there in the chat. As always, Kit is right on top of those things, and that's probably a good time to welcome Kit to the evening and to say thank you very much for the last few weeks. It's been fantastic. As always, he's on top of everything and has all the information for you. So if you've got short course general questions, please ask Kit. Having said all of that, I think we've got nearly everybody in here. So I am going to hand over to, Dr. Basu is going to start again as always this week. So welcome to you. How are you today?
Good, thank you, Shane. We'll start with Module 4. Hello, everyone. Welcome to Module 4. This week, our topic is ethical, legal, security issues, and the future of health informatics. Like every week, we will have 4 topics to cover today as well. In topic 1, we will be focusing on ethical and legal issues in health information management. Topic 2 and 3, we will be exploring security issues and health informatics megatrend, which will be addressed by Dr. Mohammed Khalifa. And finally, we will be wrapping up this module by discussing the future potential of health informatics. Let's start with our first topic, that is ethical and legal issues in health information management. Moving further in this topic, just an introductory concept, or I would say a background. When we talk about health informatics, it is the responsibility of health care provider or healthcare professionals and their partner to keep patient data confidential. However, electronic health record face significant risk of data breaches. We are well aware about those examples. With the rise in digital health tools like electronic health record, biomedical sensors or biomedical devices, telehealth, etc., health information exchange, etc., the need to protect sensitive health information is more critical than ever. Therefore, it is important to understand this topic, understand data protection laws. We basically have three major concepts in this area. Moving further and going to understand what are these three main laws we need to be aware and we need to understand. They are privacy, confidentiality, and security. Now, what is privacy? Privacy is the right, the patient right to control who has access to their personal information. For example, if a patient visit a clinic and doesn't want their, let's say they have HIV, they doesn't want their HIV status disclosed to anyone, including their family member. Even if the information is in the medical record, it is their choice, it is patient choice who gets to know about their medical condition. So privacy basically ensures the patient has control over how their data should be utilized or where it could be shared. They have the full control to make the decision. Moving to the second law, that is confidentiality. Confidentiality is the provider's duty to protect patient information from inappropriate access, use, or sharing. For example, if I'm working as a nurse and I see my neighbor's record in the hospital system and tells a friend that he or she has cancer, I should not be doing it because it is breach of confidentiality. Moving to the third law, that is security. Security means the system's protection. So, health data should be protected from being accessed, altered, or destroyed by unauthorized individual. For that, a hospital normally have strong password policy, encryption, and access log to make sure that only authorized staff can access a patient record from electronic health record. Moving further in this privacy, security, and confidentiality, in previous slide, in slide 4, we introduced the core three principle which we all need to understand regarding protecting health data, protecting patient health data. This slide expand the concept a little bit more. So in this slide, we basically are trying to understand how the privacy, confidentiality, security can be implemented. For example, there are many terms used here: accountability, authenticity, availability, etc. So let's consider an example here. For example, privacy and confidentiality. Privacy and confidentiality rely on systems that support accountability and authenticity. The concept may be getting a little bit complicated here, so we'll try to explain you with the help of example. For example, imagine a telehealth platform that allows patient to consult with the doctors online. We think about accountability in this environment. Every action, like accessing a patient record or writing a prescription, it is logged with user ID and timestamps in the system. So if there is a data breach or misuse, the responsible person can be identified, or that person will be accountable or responsible for that breach to happen. If we talk about authenticity, patient and provider can use multi-factor authentication, let's say two-factor authentication, where whenever they are logging into the system, they have password and then they will get a code. For example, in Microsoft Authenticator app, and then they can enter that code to log, and then the system will let them to log in and access patient information. If we talk about security and if we implement security using these terminologies, security can be achieved through safeguards that ensure, for example, availability, confidentiality, and integrity. Uh, let's say a hospital uses a secure electronic health record system with the availability safeguard. This means the system should have a backup. It may be using cloud-based access, so patient record are always available, even during a power outage or if there is any disaster situation happening. So we will not be losing patient data in healthcare. Similarly, if we think about confidentiality safeguards, doctors and nurses log in the system using unique password and role-based access. This means only authorized person can have access for the data, and their access will be limited. They may not have full-fledged access for whole patient data. Depending on their level or depending on their role, they may have access for the limited patient data. For example, if somebody is working in admin, they may have just a patient record, how many times they have visited, when is their next visit schedule, etc. They may not have all the data available regarding the disease, regarding the symptom, regarding the medication, regarding the other things which they are not ready, they are not needed. So this is how we can implement privacy, confidentiality, and security in terms of patient health data. We have many framework which also guide us and provide some guidelines about how patient data should be handled. For example, we have fair information practice principle. They are the set of internationally recognized guidelines that govern how organizations should collect, use, manage, and protect personally identifiable information of the patient. These principles also aim to ensure ethical data handling, especially in the digital world, in the digital environment. For example, they have principle of transparency. um, According to this principle, individuals should be informed about the collection and usage of their personal data. Then they have the principle of individual participation. Individuals, and this principle indicate that individuals should have access to their data, be able to collect inaccuracy if correct inaccuracy if they find any inaccuracy in their record or in their address or in their symptom or in their medication, and provide consent for its use. Then we have principle of purpose specification. This principle guide us that data should only be collected for a clear and specific purpose. This means we should have data minimization. That is our next principle. This means a data minimization means only the necessary data should be collected and retained for the shortest possible time. We should not collect the data, unnecessary data, or all the data which is not needed for the specific purpose in healthcare. This fair information also have more principle in the next slide. For example, use limitation. This indicates that data must not be used or shared beyond the purpose stated at the time of collection. Then we have the principle of data quality and integrity. This indicates that data must be accurate, complete, relevant, and up to date. We also have principle of security, which indicate that again the strong safeguard must protect data. For example, it should not the system should not allow unauthorized access of data, and that can avoid the breaches to happen with data. Then we have the last principle in fair information, that is accountability and auditing. This indicates that organizations must ensure compliance. They should provide the training to the staff and audit their practices regularly. So basically, these two slides are indicating providing a comprehensive framework for responsible for ethical data handling in healthcare domain, which I would say somewhere are or somewhere serve the purpose or somewhere a basic guideline or foundation. I would say for various privacy law, um, like we have HIPAA, we have GDPR, etc. And they also help organization to build trust, to build public trust, to build trust with their patient. They also ensure legal compliance, that organization is following the compliance, and prevent data breaches and misuse. Including these ethical principle of data handling, we also have more principle coming from Australasian College of Health Information, in short called as ACHI, and from International Medical Informatics Association. What ACHI says? Archie says that including biomedical ethics, which we looked in the previous slide, we should also incorporate professional ethics, organizational values while we are handling patient data. Looking at Archie's code of ethics, we have 4 code of Archie's ethics. These codes are professionalism and integrity. That is the first code, which indicate that all health informatic professionals should work with honesty and maintain a high level of competency in their work. It is it is very normal that if somebody is new in this area, then how we can say that person has a high level of competency in their work. In that case, if somebody don't have higher level of competencies, then it is their responsibility to acquire those skills and the knowledge in their particular area. Another principle of Archie says respect for rights and interest. So the healthcare professional and the health domain, must also respect the right and interest of all the stakeholders. It may be patient, employees, colleagues, and the public and the broader community. Moving to the third principle, it says patient and public interest protection. So it is a fundamental aspect of their role, which involve protecting patient data. And in certain circumstances, if they have to identify patient data, then it should be for the improvement of the society. It should not be for damaging the individual or for damaging the society. If that can bring well-being in the society, then may have to go back to data, may have to identify what is happening with certain community or people from certain religion. In that case, these laws say that yes, if it is bringing something good for the society, then we may have to go, we are allowed to identify the individual information. Moving to the last law, that is upholding the profession. Again, this law indicate that we should promote high standards and reputation of health domain. So basically, if we align these law with fair information practices, and if we think about how we can implement them with the help of fair information practices principle, we can think about when we are saying to protect public interest, we can relate it to the data quality and security. For professionalism and respect for right, we can say that it is somewhere reflecting the principle of access and accountability. Only um, the person who are allowed to access those data will have only access to those data. Unauthorized person cannot access the data. Moving further and talking about IMIA principle, this also provide a framework for ethically managing personal health data. This has again further, would say, 8 principles. So first principle is information privacy and disposition principle, which indicate that individual have the right to control how their personal data is collected, used, or stored. Then there is the principle of openness, which indicate that people must be informed about how their personal data is handled in a timely and transparent manner. Security principle indicate that personal data must be protected against unauthorized access or losses as well as misuse. The fourth principle is principle of access, which indicate that individual must have the right to view and correct their personal record to ensure accuracy and relevance. Moving further to the next principle of IMI, that is principle of legitimate infringement. This principle indicates that privacy right can be limited, but only when it serves a valid public interest, such as during public health emergency, and must be justified. So if we are identifying an individual person or patient data, it should be for the primacy of the public interest. This means it should be for the betterment of the society, not for harming the individual or not for harming the society. Then we have the principle of least intrusive alternative. This means if privacy must be infringed, it should be done in at the least invasive way possible. Last principle is principle of accountability, which indicate that any breach of privacy must be explained and justified. If there is any data breach happening with an individual, that should be explained to the individual and should also be justified what was the reason why it happened. So it should be quickly communicated, and how what will be the further controlling mechanism, all that information should be um, um, notified to the individual, notified to the patient within the certain hour or within the certain days according to health institution protocols. Moving further, and then we have international legal framework as well. At international level, many countries have established privacy law to protect personal information, particularly health data. While the specific approaches and the degree of emphasis on privacy vary from country to country, there is a growing global consensus that the privacy of health information is the most important thing, because patient data is the most valuable thing. So every country, they have their own laws for protecting patient data. For example, the European Union has traditionally taken a more stringent and proactive stance on protecting personal data. We have regulation with European Union called as GDPR that reflect European Union commitment to strong data privacy right and control for individual data. Then we also have HIPAA compliance, that is, I think, from United States. In Australia as well, we are using Privacy Act 1988. We have many other act available here. I have written in my diary. My Health Record Act is also available. Then they also have state and territory privacy laws for protecting patient information, for protecting patient data. So up to here, we have tried to understand how the patient data should be protected, what are the various protection measures we can take to look after patient data, and under what circumstances, if we have to identify patient data, under what circumstances we can do that. That should be only for the betterment of the society. So we done with this particular part, and now moving to the next part, talking about secondary usage of electronic health record. Before we enter into secondary usage, we first need to understand what is primary usage of the data which is collected in electronic health record. So the primary usage of health data may be when for example, administrative staff is collecting patient data. They may be collecting it for the billing purpose, or they may have to send the reminder, scheduling reminder, or they may have to schedule next visit for the clinic. So that is the primary usage of the data. But based on the data which has been already collected, for example, it is for billing, for administrative, for scheduling purpose, or for resource management. uh, it still has potential. It holds the potential to provide much deeper insight. So when we are looking to use that data to understand the deeper meaning of what it can convey, that is called as the secondary usage of the primary data. Let me explain you with the help of example. For example, a hospital routinely collects patient admission and discharge data for administrative purpose. That is the primary usage of the data. Later, researchers analyzed this same data set to identify seasonal trend in hospitalization due to respiratory, let's say, illness. This is the secondary usage of the data. This secondary analysis will help the health institution to prepare for example, flu outbreak by forecasting the demand for hospital bed and staff during the peak season time. Let's say people here are getting more sick, getting more cough and flu in the month of June because it's winter here. So when primarily for past 1, 2, or 3 year, the data collected for throughout the year can be analyzed and can see how many people are hospitalizing in the winter season. So primary use of the data was just because the patient visited and collected, they have been treated, their visit has been scheduled, etc. The secondary usage is if we are trying to analyze that data and trying to understand the deeper meaning. That is the secondary usage of the data. Moving further, I think I have explained the meaning of secondary usage. So basically, what value it can bring, we can see, we can find more deeper insight when we are trying to look at primary data and predicting the future. It can bring more insightful information, or it can help to integrate health services with other services, for example, with social services, with education, because we analyze the secondary data and we realize that patients are getting sick in a certain month. So and then we are looking at their mental health, we are looking at their employability status, how they are doing in their work, how many days they are calling sick. So we can come up with a very good or integrated, or we can say a patient centered care, where we have where patient know what is going to happen with their health if it is approaching a certain month or they are getting certain symptom. Moving further, I think we talked a lot about primary and secondary usage of data, so I'll skip these couple of slides. And moving to de-identification of data, I will take you through this concept later as well. But de-identification is widely adopted as a core strategy for data privacy protection, especially in health research. What de-identification means? This means the data there are the chances where the person data can be identified. It cannot be identified directly, but it may be identified indirectly for various purposes. I will expand it later in my last topic. Moving further, talking about the Australian National Data Service Guide. So Australian National Data Service Guide provide guidance on distinction between pseudonymous, de-identified, and anonymous data, which are crucial for understanding data privacy and protection. So pseudonymous data is the data where personal identifiers are replaced with a pseudonymous code. This means direct identification of the individual is possible. This data can be re-identified if the pseudonymous is linked back to the individual through a key or additional information. For example, replacing a person name with a unique code in a data set while keeping a separate file that maps the code to the individual identity. So we are keeping a separate file. If we go back to that file and we want to see who is that particular unique code or patient record belong to, then the person is de-identifiable, where re-identifiable. Whereas in the second type of data, that is de-identified data. De-identified data is the data from which direct identifiers have been removed, but indirect identifiers may still exist. So there is a risk of re-identification if the data is combined with other data set. For example, removing name and address from a health data set, but retaining information like age, gender, location, the postcode, the address, the house address, which could potentially be used to re-identify individual when combined with other data source. Whereas with anonymized data is the data that has been processed to remove all identifiers, both direct and indirect, making re-identification impossible. So if we say, if somebody is collecting the data and saying that the data will be anonymized, this means we cannot go back to data and we cannot identify the person going back to data because it is anonymized data. So basically, in Australian National Data Services, we have all these three types, and I have explained you the situation. So I hope you may be able to correlate and link in which particular situation we can have pseudonymous, de-identified, and anonymized data. Thank you very much. I will hand over to Dr. Mohammed Khalifa now for topic 2 and 3. Thanks.
Thank you very much, Vasu, for this nice and interesting topic. So now I'm going to cover topic 2, 4.2 and 4.3. Today, 4.2 is about security issues in health information management. And we are going to talk again about, very briefly, just as Vasu mentioned, the difference between privacy, confidentiality, and security, because these issues are very important to be considered for the security of the information. Generally, privacy, as Vasu mentioned, is more relevant to the human, like the human body, for example. Confidentiality is more relevant to the information. And security is more relevant to protecting information from being accessed by unauthorized users, or from being lost or deleted or corrupted by viruses and so on. So we need also to ensure that people trust, and we have public trust with a balance which is needed between patients' requirements for their privacy and the society needs for improved efficiency and reduced cost as well. Some of the issues that we could have is that when you increase the security over the access to the information, you usually lose some of the accessibility because when things are easy access, they are not really protected. Just like your door at your home, for example, if you put more locks to protect the security of your house, then you are reducing the accessibility. So we need to balance these two concepts. Many concepts needs to be balanced as well. So the HITRUST, the Health Information Trust Alliance, they have common security framework, which includes 13 security control categories like information security management programs, access control, human resources security, risk management, security policies, organization of information security, compliance and asset management, physical and environmental security, and so on. So among these different standards or elements of the framework, you could discuss each one individually, and then you could discuss the interaction between these standards and items together. So increasing security threats in healthcare data, some people would argue, someone would ask, do you think that hackers would be interested in accessing a hospital information system or electronic health records? Actually, yes. We have studies that many of the threats are targeting health data, because these health data includes Visa cards, MasterCards, payments, sometimes personal information that these hackers could be using to blackmail people or to have their information sold to a third party or something like that. So we know that there is a threat to the health information, and because hospitals and healthcare organizations are still known for their least security compared to other vendors like communication companies, banks, for example, and so on. So organizations like hospitals, they are less protected compared to banks and other industries. This is why we find more and more cyber security attacks and cyber attacks on these health organizations and health information. When we look at the National Institute of Standards and Technology, we find that we have architecture description and organizational input. And then we have 6 steps. For example, the first is about categorizing the information systems and then selecting security controls and then implementing the security controls and then evaluating these security controls and authorizing them and then monitor for these security controls. And then we also learn from that, just like the PDCA cycle, which is plan, do, check, and act. We learn from the cyber attacks that happen to the information stored in healthcare organizations. And we have actually 3 security vulnerabilities. The first is the external events, which includes outside attempts to access the organization network, or what we call hacking, intrusion of the firewalls, malicious codes and software and viruses and so on. And then we have the internal vulnerabilities like intentional or unintentional or lapses of judgment or ineffective training that could lead that some people would leak the information that they deal with. They might copy some of the information on external USB memories, for example, or share their passwords and accounts and so on. And then the third one is the medical devices, because these medical devices are integrated with the electronic health record and health information systems. So these medical devices could represent one of the points where the leakage of information and data could happen at the point of integration or the interface between these medical devices and the electronic health records. So this is why we need to understand the balance between the accessibility, the easy access to the information, and the security, so that we can achieve the balance and achieve the good privacy and confidentiality. When we look at the security controls, we could classify them into physical, into technical, into administrative. For example, administrative safeguards. Safeguards includes policies and procedures and training so that end users know exactly what they are responsible for, accountabilities, how to deal with systems, not to share passwords. All of these things are considered administrative safeguards because we have the policies. The technical part is about usernames and passwords and two-factor identification and authentication, disaster recovery planning, external, for example, servers and cloud and so on. The physical ones, for example, include access to buildings, access to rooms, keys and doors, and protecting the servers in special areas, putting cameras and so on. So we have these three levels: the physical, the technical, and the administrative. And when we look at the cybersecurity in Australia, we have security checks of the Australia's healthcare information, and we have some of these reports are issued by the Health Informatics Society of Australia, and they are reporting different. They did the survey in 2017, and this one was updated, I think, 2024, but it's not issued yet. So the interviews and surveys investigated the leadership, the culture and staff responsibility and their level of awareness, including training, the policies and procedures in healthcare organizations, the general cybersecurity knowledge, including IT professionals as well as healthcare professionals. And then who's responsible for information security? Is it the patients or the doctors and nurses or the hospital IT team or the administrators or the directors and managers? So we will find eventually at the end is that everyone is responsible for the security of the information and the privacy and confidentiality. Now we have the NIST cybersecurity framework, which starts with identify and then protect, detect, respond, and recover. So we need to identify what is happening, what are the risks, and then how to protect them. And then we implement the protection through access controls, usernames and passwords, awareness and training, data security, information protection, maintenance, and technology. And then we need to detect if there are incidents, if there are events, security monitoring, detection processes should be included. And then we need to understand how to respond. What is the response plan and the communications about any incident that happens, how to respond to the general public, how to respond to the patients, how to respond to the healthcare professionals when we have leakage of information or breach. And then we need definitely to have a plan for recovery and then improvement and then communication. The state of cybersecurity and cyber maturity, in terms of identification, we know that 33% of the healthcare organizations said that they did a kind of cybersecurity risk assessment at least every year. 65% had formal business or governance plan, which includes managing cybersecurity issues. When we look at the protection, for example, 84% of organizations have, healthcare organizations have backup systems. 15%, they said that they never used work devices for personal use. So they ban personal devices like mobile phones and tablets and laptops from accessing the network of the hospital and providing information or retrieving information, only 15%. 40% installed operating systems, patches, and updates within 48 hours, and 32% only after extensive testing by IT teams, so they don't really update automatically, which is good because updating software sometimes comes with these types of threats. Now, in terms of detection, 43% maintain a central register for end user devices and what type of information they accessed and who accessed the information. 35% were either unaware of any process or were certain no tracking procedures were in place, which is an alarming percentage. It's 1/3. Now, in terms of response, 55, almost 55% respondents indicated that they knew what to do. 9.8, almost 10% were unsure, and third were not clear at all. 34% of organizations will refresh their systems and hardware before or shortly after vendor support stops, and then 22% of organizations continue to use end-of-life systems without vendor support. So end-of-life systems, we mean the supportive systems like ventilators and intensive care devices. So they keep working with these systems, 22% without vendor support, which puts them at a risk of technical failure as well. And then the last one is the recovery. We find that 23% almost of the organizations in healthcare indicated that there was regular business continuity testing, testing their cloud systems, testing their recovery servers, hard disks, and recovery plans, and so on, while 25.8% did not do regular testing at all. Now, let's move to the third topic today, which is about health informatics megatrends. Now, when we say megatrends, we mean that we have certain societal, technological trends that support and shape the health informatics industry and health IT. One of these could be the healthcare costs, because we have a continuous growth in the costs of providing healthcare, which means that this is going to include also the developments in IT, developments in software, developments in hardware, sensors, monitors, even artificial intelligence and machine learning and algorithms and sophisticated software applications. They are also included in these healthcare costs. The aging population, for example, in Australia is another driving force because not just in Australia, but in many other countries, we have aging populations where people live until the age of 80 or 90 or 100. And this means more resources needed, more staff, more technology to be used to improve the efficiency of healthcare services. And then the increasing burden of non-communicable diseases like chronic conditions, which also contributes to the burden of these services, and is very closely linked to the aging population. And then the predicted shortages of healthcare professionals, like shortages of doctors and nurses everywhere, not just in Australia. So these are among the societal trends that we have that could shape the future of health informatics and health information technology. So we also have applications for future research. How can health informaticians use the methods and strategies from future studies to try and ascertain what the future may hold? For example, today we find AI highly interacting with health information, and we still have some privacy, confidentiality concerns and regulatory concerns regarding using AI, because no one knows exactly where the information goes. When you put some information on ChatGPT or DeepSeek or any other AI or Copilot, you don't have a clear understanding of who else could have access to this information that you have just posted. So the key future directions, we will find many of these studies mentioning the mega trends that we have, but mainly Manat's mega trend shaping healthcare providers. Let's look at the Manat's report. We have here 11 mega trends. The first is consumers take charge. So today patients are equipped with information, with details, with more and more power to make decisions regarding their own healthcare. So they are taking charge, not like 30 or 40 years ago, when we used to have the doctors and nurses in like a parent relationship with the patients, telling them what to do and what not to do. Today, consumers take charge, patients take charge. The second is from volume to value. Instead of looking at quantitative concepts, we consider qualitative concepts in terms of value rather than the amount of information or data that we collect. Healthcare everywhere, because we have smartphones, wearable devices, connectivity, interoperability between systems. Everything is connected to everything else. Mega healthcare systems, because we have more mergers, more public health systems, like in Australia, for example, which is a mega health system. And then centrality of the state, which means that the government lies at the center of providing these public healthcare services. And then value through data, predict, prevent, and personalize, because more data, more intelligence, more information, big data analytics will help us to predict and then to prevent conditions like health promotion, and then personalized healthcare diagnosis and management. Employers recalibrate their staff skills and required skills. The new aging population, nowadays we have more and more older people who have a little bit better technology awareness and use compared to 20 or 30 years ago. Healthcare goes global and then focus on the whole person rather than focusing on specific or limited aspects of healthcare. Now, the mega trends reshaping healthcare, we will find that healthcare everywhere and then value through data are among the most important mega trends that we could talk about in more details. Definitely, you will find more information on different reports. So we have so much comparisons and details here. Now, when we look at PwC reports for the annual white paper on industry trends, it's certainly worth reading, comparing 2016 to 2019, and then we have 2023. So we will find that the list has been a little bit updated with more digital therapeutics, connected care, with more creating of private equity, Affordable Care Act in 2019, and so on. So there is a shift towards empowering end users and people and health consumers and the public regarding their healthcare, which also is not just a technology thing. It's not just a technology dimension. You could argue that this is politics, this is elections, governments. Yes, it's true. Now we move to the next, which is the 8 disruptive technologies that we could have, changing the landscape of healthcare, changing the way we provide healthcare services, including artificial intelligence, definitely, augmented reality and virtual reality, which is going to change the way doctors and nurses train and the way we care for patients and so on. The blockchain for securing the interactions and transactions and information exchange, using drones, for example, which could help in supply chain, delivery of healthcare goods, to consumers, emergency or even disaster response, Internet of Things, robotics, for example, robotic surgeries and Da Vinci systems, and completely automated robotic procedures, for example, and then 3D printing, like printing joints and printing small bones for implanting these small bones, like implanting teeth and cheekbones and so on. These are used by 3D printing. So these are technologies that are going to completely change the face of healthcare almost completely. Now back to Fazoo to cover the last topic today.
Thank you, Muhammad. As Dr. Muhammad has already given us the future direction, so we'll explore a little bit more in this area. We can look at some ideas futuristic in our futuristic magazine. We can think about tiny, tiny chips which can be used to design miniature sensors and processors and can enable wearable health tech, which is happening nowadays. We have a huge amount of transmitted personal data. So we can think about what we can do with that data, how we can move to analyze it, and what analysis, what insights, what knowledge, what wisdom we can get from there. In our future magazine, we can also consider that the new skills for leadership. These skills are like we used to earlier have. If somebody working in medical domain need to have those skills, but now including those skills, we need to think about how AI, how technology, how various tools, technical tools are getting implemented. What are the ethics around data? What are data ethics? What is cyber security? And obviously stakeholder engagement is not a new skill. So these skills we have to think, and we may have to revive these skills. Then we also have nanotechnology, and such as nanobots. These are like microscopic robots that can navigate the human body for targeted treatments or surgery. We can also think in the future, think about the firewall, full body firewall. That is a metaphor for personalized cybersecurity that protect health data across multiple devices and networks. So, for example, a firewall can protect device like if somebody have pacemaker inside their body. Then we have ubiquitous computing nowadays, where we say ubiquitous means technology everywhere. So we have it in home, wearable, smartphone, and even with our clothing, with our jewelry, with our shoes, everywhere. So we can say it's a ubiquitous computing trend now. We can also have image driven communication in our futuristic magazine. That is use of medical imaging, telehealth video, and visuals in patient communication to enhance understanding of the care. We also have live data, which, for example, the data that is constantly updated in real time, such as from the biosensors, from electronic medical record, or from patient wearable. So that data we can see if somebody is in ICU, how it can help. So probably ICU monitoring system can continuously feed live data into the dashboard, where if somebody need rapid help or rapid intervention, that can be immediately provided. We don't finish our futuristic magazine here. We say we have more. We have artificial intelligence. We have more new ideas, or some ideas are already getting utilized in our next slide. For example, we have telehealth, we have home health, we have e-patient, which we covered in our previous module. We have social media. We have many technological tools available. We have my health record. We have mobile health, etc. So we have many trends which are happening, and we can also think how we can improve or how we can expand them in the future. Moving to next slide, please. Next, please. So basically, if we look at the future potential of our health informatics, we have many areas where we can think about, we can proceed with the career, or we can work on. Here we just have mainly four pillars of future potential for health informatics mentioned, which some of them you can see they are happening. So in this diagram, we have mainly four pillar, that is electronic health record, care everywhere, then patient data integration, and the Internet of Things. When we talk about electronic health record, as we know, their main purpose was to keep patient data. So main purpose of electronic health record was to smoothly run the health organization, the workflow of the health organization. But nowadays, we have many other applications and technology available, many sensor system available, many applications available. So various health informatics tools are somewhere uh, letting us move forward, or I would say they are evolving the healthcare, where we are saying ubiquitous healthcare, or we can say healthcare anywhere, anytime. I'll probably move to the next slide. Next, please. So we can see when we are talking about care anywhere. So we basically have here some figures or some dotted points, which says that monitoring and on-time intervention. These are some value-added features of care anywhere. So this indicate that continuous tracking of patient health allows early detection of any health issues if they are struggling with, and a prompt clinical response. Another value added feature of this care anywhere is integrated care, that is coordinated services across multiple providers, which ensure holistic management of healthcare condition. Then we have self-care, where the goal is to empower individual to actively manage their health through education and access to tools, and leveraging leveraging family, community, and peer network to improve health outcome and provide emotional support. Moving further to the next pillar of our futuristic, or the things which are happening now, I would say this is somewhere we can think about in our futuristic healthcare, that is personal data integration. Nowadays, because we have many emerging technologies like smart devices, smart lenses, smart home monitoring devices, these are creating a growing need to integrate data from multiple sources while ensuring security, strong security and ease of use and effectiveness to support timely intervention. Moving to the next trend, that is Internet of Things. Um, Looking ahead, industry experts see the Internet of Things as a major driver for healthcare innovation in coming year. So future uses could include high quality remote physiological, for example, monitoring devices, maybe smart staffing system that match nurses' experience with patient need, etc. And they are also pushing the personal data integration. Moving to the next one, that is improving user experience, because the health devices and the technological devices or the health applications are continuously evolving, the need to thoroughly access user experience is becoming very important. As a digital tool become more integrated into everyday healthcare and the new tools are appearing, so there is always ongoing research in this space, where if you are thinking to go in research area, may also think about where need to know about the effectiveness, efficiency, and satisfaction with a particular technological tool or with a particular health application. So these dimensions, that is effectiveness, efficiency, and satisfaction, they help determine whether a device or an application is truly supporting its intended purpose, enabling user to perform the task with their minimal efforts, bringing ease of use, etc., making their life comfortable, etc. So it's really important to explore the future trend and what are the usability issues with those technological trends. Moving further, we have talked about it a lot. Big data, yes, data is a gold mine, I would say, for everyone in every domain, including health domain. So due to big data getting collected through various technologies, it is important to understand what meaning it can convey for a domain, what meaning it can convey for a patient. So saying that we can do much more deeper analysis of data, and somewhere we can look at what the future can bring. So moving further, for example, we say predictive analytics. So predictive analysis involve where we can see what is happening based on the past data. We can predict something for the future. That is predictive analytics. Moving further, where we have the some kind of summarization of various types of analytics. So with the help of data, we can do the descriptive analytics, we can do predictive analytics, or we can do prescriptive analytics as well as cognitive analytics. So basically, this slide is conveying that if we have data available, we can focus on understanding what has happened in the past. That can be presented in the form of report using various visualization tools. Basic visualization tool can be represented in the dashboard. That is descriptive analytics. In predictive analytics, we can use historical and the current data and can apply some statistical model and machine learning to forecast the future, which can, for example, can tell for an institution about the disease outbreak, how many resources they have to manage if there is any outbreak happening. Then we also have prescriptive analytics. Prescriptive analytics suggest actions or decision based on predictive insight to optimize the outcome. So basically, prescriptive analytics can be used to reform policies or to create the new strategies for the organization. Then we have, because the AI is getting utilized and we are talking a lot about AI, so we can think about the cognitive analytics as well, which can be incorporated with AI and natural processing to mimic human reasoning for deeper insight. So, for example, we have a clinical decision support, we have chatbot, etc. So we can think about that type of analytics as well. With this, we done with our module 4. Thank you very much for listening and happy to take your questions. Thank you.
Hey, there's lots to process there. There's so many things coming along. Although I will say that having worked in IoT for many years, a lot of that stuff we were talking about at various times for the last probably 15, 20 years since data over mobile networks became a possibility. So what does happen is that the reality of it becomes closer every year. We've got a few questions. I would encourage everybody to ask more questions now. We will keep the question line open for about another 10 to 12 minutes. Let's start back at the beginning. What takes precedence with security, patient protection or public interest?
I would say public interest, because if I recall about ACS principle, and then it says that if we should keep the public interest at primacy. So the more, if we have to ask whether we should keep individual interest at priority or public interest at priority, so we need to think about, the ACS principle says that we need to think about the public first, then individual second.
Hey, um, is there a standard methodology for de-identifying data? We've all heard stories where, Google in its search data would de-identify it, but then that people were able to figure out who was there. There was a very famous case some years ago, apocryphal, I suppose, where a young woman was asking about pregnancy tests or something online and got a whole pile of spam about that from Google, even though her data was de-identified, and her parents picked it up and realized she was pregnant. Um, uh, you know, how do we de-identify in a meaningful sense and keep that going?
Uh, Maybe I'm just thinking about, in that case, if that is happening, the penalties should be applied on the institution, because this means they are not following the laws. For example, we have HIPAA compliance, we have GDPR compliance. So this means they are not following. If somebody is searching and googling, and if their data is identifiable, then the strong security measures are not available there. This means they have breached the law. So in that case, the penalty should be applied.
Yeah, I
On
think that one came pre-GDPR. But what's the standard methodology for de-identifying data now?
There are standard rules. There are many framework. They are also, I think, mentioned in HIPAA compliance. They are also mentioned, I think, in GDPR. So many frameworks are applicable and available, which convey under what situation that data should be identifiable. We cannot like leave data where everyone can see everybody's record. So we have methodologies and frameworks available. They enforce laws. And if people are, or institutions are not following them, then they may be penalized millions dollars.
This one's from Stephen, and I'm going to part answer it because I'm aware of some of the answers. He's saying everyone's responsible for health information security, but the buck has to stop somewhere. Where does it stop? The CIO of the organization that's storing the health data? That's partly right, but there's new laws coming into place in Australia where company directors are going to be held responsible for major data breaches. That's going to be a can of worms.
Yeah, I think it's not only one person responsibility. It is institution responsibility as well as the employees working there. It's their responsibility as well that they don't uh, disclose their patient data or somebody in their neighbor. And if they know about what is happening with their health, then it is everybody's individual person responsibility as well. So including health institution, it is the employees, the people who are working in the organization, their responsibility as well, not to disclose the information, patient data, to everyone. And there are like role based access as well, where everyone don't have access to everything.
When it comes to data security, we seem to have a few questions about that, but this is a combined course with IT Masters people, many of whom are studying cybersecurity. When it comes to data security, there seems to be some distance between theory and practice, as in all organizations. How
Yeah.
common is credential sharing in healthcare settings? Are there audit programs in force which can provide a reliable picture that shows what happens in everyday practice?
There should be auditing happening and that normally happen, because wherever we see, always there are some protocols in the organization which should be followed. So that also happen in health institution as well, where auditing is done. I think Dr. Muhammad Khalifa may be able to add here a bit more. That ensures that those protocols have been followed when it comes to data sharing. And yeah, it's institution responsibility as well, where they train the people who are working in their organization. They need to educate if somebody is new in that area. For example, new employees joining, then they need to provide it some training, some education, and then yeah, role-based access as well as multi-factor authentication that can can help to secure the data, and auditing procedures are also available, and that in fact with every organization. I think I'm not quite sure, Dr. Mohammed may be able to add.
Yeah, I completely agree because we have to start with the policies and procedures based on the regulations that we have from each country or government. And then from that, vendors usually develop their platforms that comply with these regulations and these policies and procedures. And these platforms or engines, or like the HIPAA, for example, in the United States, the Health Information Portability and Accountability Act, HL7, and different types of platforms that have been there for more than 20 or 25 years. And today in Australia, we also have these data exchange protocols and regulations, so that we protect the confidentiality of moving this type of data from one place to another, including the identification and everything, and coding and other procedures that we could follow to share the data and to transfer the data from one place to the other. Yeah.
Hey, I'm just going to interrupt the question flow for just a second.
Hmm.
If you've all been really enjoying this course, I would say this is a fairly clear example of some of the subjects that the College of Health Science offers, just so that everybody's aware. Dr. Mohammed Khalifa and Dr. Basil Sood are both lecturers and course designers within our course. And this is precisely, in fact, these modules come primarily from one of the subjects. I think it's HM005, which you would do nearly halfway through your progression toward the master's, or just after, or I think towards the middle of your graduate diploma, for example. So just keep that in mind, because that is the purpose of providing these free short courses. We figure that if we let you know a little bit about what we do, then it's a good chance for you to be able to catch up and see it in real life, and maybe find out that it is the right thing for you or not. Okay, moving on to the next question. Shouldn't the codes of ethics for processing and storing electronic health records start to incorporate the increasing use of AI?
Yeah, definitely AI is going to represent one of the major things and issues and concerns that we will have when we implement integration between different technologies, including AI with electronic health records, AI with diagnostic imaging, radiology reporting, dictation systems for electronic health records, nursing notes, doctor's notes, and so on. So we need a better vision on the accountability of the AI engines and their vendors. For example, OpenAI company that responsible for ChatGPT, for example, or the Chinese DeepSeek. If we are, as we mentioned in the lecture like a few minutes ago, if we are posting some of these information or integrating AI into electronic health records, what are the forms of safeguards that we can implement to make sure this information is not misused or abused or leaked to a third party or anything else of these issues? We still are going to learn about AI over the coming few years, like 3 to 5 years. We are going to learn more about the incidents that could rise because of the integration of AI into health information systems. But definitely, we don't have a clear vision yet on how AI is going to securely manage the information or the data from electronic health records or other sources in healthcare. It's a big challenge that we still have to face and learn.
And the questioner also suggested that, you know, AI can perceivably have bias and that can bleed through into their answers in this
It
area.
can, yes, we know that there is algorithm bias because AI models are trained on certain data sets that could be less representative of the global population. For example, if the OpenAI company used, let's say, European white, for example, white people data to train AI on medical tasks in terms of diagnosis and management, for example, then this could be different for colored people, for Black people, for African, for Indian, for Chinese. So this is what we know as the algorithm bias. And it's very well known in technology, just like facial recognition, for example, voice recognition, accents, and so on. So we still have to face this kind of challenge and learn more about what's going to happen and how to mitigate the risks that this threat could bring to healthcare.
Mind you, a lot of those biases are in testing anyway. Look at the
Yes.
lack of female participation in trials over many years.
Yeah.
There've been many instances of ransomware attacks for healthcare organizations, pulling their data out and making it inaccessible. What do we do in cases like this? What's the plan?
Well, the ransomware, it's part of the cyber attacks that we were just talking about, and we should not be allowing the data to be leaked outside, and the data should always be de-anonymized, and the data available on servers should be, for example, should be split into two parts. One part could have the identification information, identifiable information, and the other part could have the financial or clinical information. So if anything happened, we should not be seeing a complete leakage of information that could be used to blackmail someone or use their information in a more like threatening pattern. Yeah.
Hey, we've only got a few questions left. We're going to close the questions in a sec, but we've got a couple left.
Okay.
Tim, with the increasing number of medical IoT devices coming to healthcare spaces, i.e. hospitals, which I assume are very expensive, are these IoT devices becoming an increasing cybersecurity weakness if these cannot be as easily updated with security patches, or they have to be replaced frequently at a great amount of dollars?
I think Vasu could answer this question about.
I'm just thinking if you can repeat the question again, Shane.
So there's a pile of IoT devices that are in hospitals now. He's assuming they're at great cost, which is actually probably not a correct assumption because most IoT devices are pretty cheap. But anyway, but if are they becoming a bigger cybersecurity weak area because you have to update them constantly and it's hard to update very cheap devices or very small devices? Or do they consistently have to be replaced so they can be patched and upgraded?
I I would say it can happen both way. Yeah, they may be vulnerable. They can be attacked easily because they are not they are the part of big system, but actually they are not big system. So more focus will be on saving the data. For example, the data which is in electronic medical record. Excuse me. But we cannot deny that if the authentic devices, these IoT devices, if they are authenticated by the standard organization and if they are allowed to use in health institution, then they should be less prone to cyber security attack. But if we are using our personal devices, then for example our mobile applications, our smartwatches, then I would say I cannot assume that there would be 100% guarantee that the data will be secured. So now we are looking in our futuristic health magazine, we are looking for integrating the data. So integration of data coming from these various sources, we must have to think about securing that data. So if the devices, small devices, wearable or implantable devices are coming and getting used in health institution, I would trust more on those rather than the data which I am collecting in my personal mobile phone. I would trust less on that data. I would think, yes, there are the chances it can be easily hacked. A very simple example, my bank account got hacked. So that I have all the information in my mobile phone. So I would say I won't 100% trust on the devices or the application which somebody is using there just for their personal use.
The principle of legitimate infringement, sorry, is that for a notifiable disease, is it?
Yeah, no, for notifiable diseases, like for example, COVID-19, we can't say that a patient has a choice not to report his case to the government because these notifiable conditions, by law, we have to report them to the government because this is for the public interest. We don't have, we can't really provide the patients with privacy or confidentiality of such information. Yeah.
Are the standards for securing implantable medical devices like pacemakers improving?
Yes, yes, there are standards for securing the data that implantable devices are using, sending and receiving. Yes.
Okay, here's a couple of future sounding questions to finish off on. What's neurotechnology and how is it being used?
Well, neurotechnology is about all types of technology that we could use to interact with the nervous system, including peripheral nerves, including the brain, the spinal cord, including, for example, Neuralink chip that Elon Musk is planning to implant in the human brain. People get skeptical about if that is going to impact their way of thinking, could impact their personality, could add information from outside sources, or extract information from the brain and communicate that information to other systems or devices. So we are still in the testing phase of these neuro technologies, including mainly data and information transfer to and from the human brain mainly. But other things related to peripheral nerves or motor nerves, or replacing, for example, amputations, or organs or limbs and hands and feet and so on. These could be considered hardware rather than software, but still it's a neurotechnology. Yeah.
Okay, and on the same note, what's the future of neuromorphic technology?
Um, Neuromorphic technology is more focused on simulating the design of the human brain in developing computer systems so that they don't consume a lot of energy or work on like high power, for example, the speed of real-time processing, and so on. But still, it's still under experimentation. The future is very high because it's not only neuromorphic technology, but also quantum computing, for example, which is a field that is outside the scope of this course or the scope of health IT, which means higher processing power, real-time processing, um, communication, or better communication of information and processing of that information in high speed with low energy consumption. So which allows us to achieve even better AI levels in the very near future, I think. Yeah.
Right. Well, I think that we've now drawn to the end of a fantastic on IT and technology in healthcare. What I would ask very quickly everybody to remember is the webinar next week, which Dr. Claypool will be hosting on AI. We will also be talking about the CHS courses during that, if you're interested in CHS. We would also remind you, please, again, one more time, to fill in the good old survey, and we'll let you know that the exam will be available fairly soon after this finishes. So you can, those of you that wish to, can hop on out, do the quizzes, get the exam, and get your certificate. So having said all of that, it's time for thank yous. Thanks very much to Kit for making everything work and being the behind the scenes guru that has helped us be able to provide this course. A big thanks to CHS itself as an organisation, which has allowed us and cooperated with us to do a joint presentation. And it's the first one we've done. And the good news is there may be more coming up. We're hopeful of being able to do another one later on in the year. And most importantly, I would like to thank all of our students for coming along and sharing so beautifully in the chat too. It's been great to have everybody on board. And finally, thank you to you, Basu and Mohammed. It's been great. We'll look forward to speaking with you again in another short course, but you guys have been amazing. Thank you.
Thank you very much.
Have a great night, everybody. Do your courses. Come and chat to us in the webinar next week. Cheerio.